Hello, everyone. It's July the 11th, 2025. This is the Room Now podcast. Hi, I'm Dr. Jack Cush, executive editor with RoomNow.com. This week on the podcast, a few new thoughts. Some things that are painfully obvious, and let's begin with some things that fall into the category of, really. Really, I'm going to start with DISH. Diffuse idiopathic skeletal hyperostosis, also known as Forestier's disease, four contiguous segments with those bulky osteophytes. I like this article that I found because it reviewed the issue of dysphagia with DISH. It's a known cause. I wouldn't have been able to guess how known or how common that is. I can't say it's ever come up. I've seen a few DISH cases, usually not in the cervical spine, but in this study, 208 patients with dysphagia, so they're looking at it from that angle, who underwent CT of the head and neck. They found that DISH was the cause of dysphagia in 39%. Really? 39%. And if that's not surprising, and it was usually they had anterior dysphagia, again, it's usually from the anterior osteophytes that are occurring as opposed to the lateral. But the real surprising thing is, what were the predictors of patients with dysphagia who will have DISH? The predictors were, 1, a low serum albumin, 2, COPD, 3, chronic pain, I assume chronic neck pain. 3, I get. The other 2, it's like, what? And I must say the article did not really get into it other than to say serum albumin may reflect malnutrition. Malnutrition related to dysphagia, you say? Well, they didn't say. I guess that's the implication. Or they said that the low albumin was due to inflammation. Well, you wouldn't think DISH has got a whole lot of inflammation going on, and nothing else in the paper suggested that other than this finding of COPD. COPD, an inflammatory disease, maybe that's driving low albumin, but what's that got to do with bulky osteophytes of the cervical spine? I find this interesting. I think that the point is that DISH belongs in your differential diagnosis of dysphagia. And don't get me started on dysphagia. It's too late. It's already happened. There's two kinds of dysphagia. There's the dysphagia up here in the throat, and then there's the dysphagia down below the sternum. Substernal dysphagia is smooth muscle, is achalasia, is esophageal dysmotility, is masses, right? Up here in the throat, up high, it's usually from a lack of saliva associated with xerostomia, Sjogren's syndrome, and whatnot, or it's psychiatric, bulbar hysteria kind of things. You see a lot of upper pharyngeal dysphagia with fibromyalgia. I don't know if it's psychologic or if it's the dry mouth that they may have. But this kind of dysphagia with here, we're talking about substernal dysphagia. I guess it could be cervical if that's being found on cervical CT. See, I told you, don't get me started on dysphagia. Another interesting report was a full read review, nice review, pretty expansive, kind of a little maybe too expansive, from Joint, Bone, and Spine, the journal Joint, Bone, and Spine. It's a full read review on idiopathic inflammatory myositis and new treatments, and it go into IVIG and FcRn receptor blockade and, rituximab and all kinds of things. But it begins with sort of an overview of myositis, and I like the way it began because it asked the question, is the term polymyositis obsolete? Dermatomyositis we use all the time. How often are you using the term polymyositis? Their contention was that it's been replaced by better understanding of idiopathic inflammatory myositis in all its labels, including necrotizing myopathy, inclusion body myositis, antisynthetase syndrome, overlap myositis, and now we have NXP2 and TIF1 gamma myositis, that we're just not using the term polymyositis as much anymore. Really? Or if you're interested in the therapies, you can look at that free full read reference. Some new thoughts from some new papers. A 1-year study looked at the risk of falls in inflammatory arthritis patients. It happens. It should happen. They're weak. They have pain. In this study, from 100 RA patients, 33% reported a fall in a 12-month period. From 80 patients that they followed, 46% had a fall in the prior 12 months, making it much more common in PSA. And they noted in their discussion that this has been reported before. When compared to RA, PSA patients have more falls. Falls were associated with disease duration and HAQ score. HAQ score, underline that, bookmark that. That's your invitation. You see patients who are checking all those boxes to the right on the HAQ score or on the MD HAQ. That's your invitation to ask about, have you had any falls? Falls, because they are associated with morbidity and mortality, is something we should be asking about. And as I mentioned, because you bookmarked it, when the HAQ score is high, maybe that's when the risk is also high. I found this interesting report about what's the predictive utility of finding MRIs in patients with very, very early arthritis. Patients who are clinically suspect arthralgia, they don't have synovitis. So I'm thinking, why are they having MRIs if they don't have synovitis, but they have maybe chronic hand pain or whatever? And yes, some of those people do in fact have erosions when it's found. This particular study of 405, this is from the Leeds Early Arthritis Clinic, I believe, CSA patients, 47% had MRI erosions. 47%. What? But again, this is sort of a select group doing advanced research. And they did say that if you had an MRI erosion, you had a 5 times greater risk of having a later subsequent radiographic erosion, odds ratio of 5. But in the overall scheme of things, 96% of MRI detected erosions had no associated X-ray abnormality, meaning that finding an MRI early on in someone who doesn't yet have synovitis, may not yet have RA, and MRI erosions, not meeting criteria RA, not yet having synovitis, does not signify proof that they have erosive arthritis. Ultimately, that has to be diagnosed by X-ray. This is like all those studies of hockey players and manual workers who have abnormal MRIs of the SI joint. The greater the sensitivity of the imaging test, the more you'll be finding things that don't mean anything. So don't get carried away just because you find MRI erosions. Maybe the thing is not to do MRIs on people with CSA, preclinical RA. I don't. Maybe you do. They certainly do in Leeds. RA patients have a 40% higher risk of serious dental infections. A study of the national inpatient sample over a 6-year period looks at all U.S. hospitalizations, a retrospective study of 15 million hospitalizations and records. 10K or 0.7% were hospitalized for serious oral infections. What were the risk factors? RA, 2%. Being male and being black and having smoking as your part of your history. But RA is a risk factor for serious dental infections, serious enough to get you hospitalized. And you've heard many times before about the parallels between gingivitis and RA synovitis, both at the histologic and cytokine level, and as far as the damage they can do to local tissues, and about the cross associations between the two. So this finding is really not that surprising. We've talked before about nerve blocks, specifically genicular nerve blocks, as an effective therapy for knee OA. I've seen these studies. I've never done it. Now I'm looking at a meta-analysis of 6 randomized controlled trials that involve 420 patients with knee osteoarthritis, and they showed significantly, like for pain, it was P less than 0.0001, and for function, significantly better with P less than 0.003, with relief as early as 2 weeks as far as pain, and functional improvement by as early as 12 weeks. We're not doing this in rheumatology. Maybe we should. Would you do this instead of a steroid injection? Well, I got steroid in the closet and in a tray. I can just do that in 12 seconds. But actually, you don't want to keep doing steroid injections into osteoarthritic knees. I think we should be doing more of these. I will. I'll be asking about them at least. And they're supposedly done by your interventional radiologist. I found an interesting study about autoinflammatory disease from a UK National Referral Center. They reported their 2022 experience with 304 referrals for suspected systemic autoinflammatory disease. The abbreviation is SAID, S-A-I-D. 39% were diagnosed with a SAID, meaning the majority of patients referred did not have an autoinflammatory disease. And half of those that were diagnosed had monogenic disease. And most of these referrals, by the way, were in an adult population. They found there was a significant delay in from symptoms to diagnosis, 2 to 6 years, especially in those who are adults, especially in those who are having a late onset of their autoinflammatory disease. What were the diagnoses that you saw? I would have guessed a predominantly adult population it had been Still's disease. No, Still's was number 5. Number 1 was FMF. Number 2 was recurrent idiopathic pericarditis. Number 3 was undifferentiated autoinflammatory disease. Number 4 was CAPS, the cryopyrin-associated periodic syndromes. And 5, my disease, Still's disease, coming in at a modest position. A lot of things after that. FAPA, TRAPS, Schnitzler's, VEXAS, ROSA, MKD, mevalonic kinase deficiency, PFID, PFIT, DADA2, and Blau syndrome. That's the experience of others. What's your experience? So now we got a bunch of reports that I think are kind of painfully obvious, but they do have a caveat and worth discussing. I began this tweet with, don't stop the DMARDs. You've heard me before saying, please don't encourage people to stop their DMARD therapies working. There's a retrospective study of 91 JIA patients. A third of them had oligoarticular disease. 25 or 27% had polyarticular disease, but they had all types being represented in there, including ERA and systemics and whatnot. And they talked about, because of sometimes the self-limiting nature of JIA and its many forms, that patients get cycles of therapy, and then when they go into remission, they stop the cycle. So in this study, they included patients who got up to 4 different cycles of therapy, and they showed that consistently, whether it was the first time, the second time, the third time, that when you stop therapy because they're in persistent remission, let's say 6 months, 2/3 of them are going to flare and relapse and require therapy again. And only 1/3 are able to remain off the DMARD. Bad news here is you don't know who they are. So those are the realistic odds, and maybe why you shouldn't stop the DMARD or the biologic. Again, about 1/3 of these patients initially were taking methotrexate and a biologic. 2/3 were on methotrexate. And then with subsequent courses, they went on different therapies. In Erlangen, the home of a lot of novel studies led by Dr. Schett and colleagues, 1,500 patients that were entered into clinical trials, I guess. They looked at how you could predict remission at 6 months, irrespective, I guess, of the therapies. They did show that they could do this with great accuracy using the ADA boost modeling, had the strongest predictive accuracy at 86%. And what did they base the prediction on? Right? This is machine learning, AI, predicting who has a greater risk of going into remission. It was based on -28 activity, age, VAS scores for pain, and the number of swollen joints. But while this is a moment, these are things that you use in your decision making. But wouldn't it be great if you actually had an AI program that told you what the likelihood of remission at 6 months was going to be? And maybe that would further inform your therapy? I think that's where we're going in the near future. The near future is often guided by our recent past. Some of our biggest questions are in scleroderma, and one of the better or often referred to studies is the U-STAR study. It's a multinational prospective study of patients with scleroderma. In this sub-study, 893 patients with ILD related to scleroderma, they found that 10% of them died. So getting ILD with scleroderma, any of our diseases, RA, maybe not myositis, but most of our diseases has a significant morbidity and if not mortality risk. So these patients were followed up to 39 months, 10% died. Predictors of mortality was sort of rapid deterioration of greater than 10% within the first 12 months. That's kind of a dumb moment. And a significant decline in as measured by their modified Rodnan skin score. So rapidly changing skin, rapidly changing lung. Again, these people have a 3 to 4-fold higher risk of death. Things that were not predictive were DLCO. You like to look at DLCO. I have always liked to look at DLCO. Usually not that predictive. An absolute score on the modified Rodnan score, it was the change that made the difference, or the number of digital ulcers were not predictive. I thought this is interesting. Another study of systemic sclerosis, 74 patients were examined by a number of different parameters. And this study showed that nail fold video capillaroscopy had a significant correlation with future ILD progression as measured by worsening of PFTs. And also, nail fold capillaroscopy also predicted worsening of the modified Rodnan skin score over a 2-year period. The interesting thing, and they did many, many measures on here, including biologic and clinical and lab, they found that KL6, something that you don't measure, that the lung guys measure a lot, correlated with the nail fold video capillaroscopy scores and also the decline in PFTs. In this period that they watched patients, the ILD rate at baseline was 38%, but went up to 51%. So some patients do progress. And maybe you can get insight into those who are at greater risk by looking at their nail folds. The predictive features were capillary disorganization and late pattern changes. That would mean big dropout, odd asymmetric morphology, large dilated vessels. That's late pattern changes. You know that cannabis is sort of like all over the place these days. It's legal in 24 states. It's decriminalized in 7 states. It's in the District of Columbia and 3 territories it's legal. And there are more coming on board. Unfortunately, HHS, as of this year, still has cannabis scheduled as a Schedule 1 drug, meaning it has no medical use and high abuse potential. In 2024, there were laws being introduced to decriminalize it on a federal level, bumping it down to a Schedule 3 drug, but that didn't happen. So we still have a lot of conflict here, do we not? It is a Schedule 1 drug according to the FDA and the federal government, but everyone's using it. And, there's no guidelines. And all the benefits and merits of cannabis use are coming from who? The authority behind the counter named Paco. This is a little problematic. I believe in the use of cannabis. I just wish there was some real research and evidence in this area. BMJ had a nice report on a UK population study of 15 million adults showing that if you have autoimmune disease, that you have twice the risk of having an affective disorder. That includes depression, bipolar disease, and anxiety. Significantly higher in autoimmune patients, like 29% compared to general population, 18%. And this was regardless of age, sex, ethnicity, income, family history, etc. Two studies on cancer that were interesting this week. A case-controlled study from 2014, 2019, and RA patients over the age of 65 compared cancer risk in RA patients to U.S. population risk using the SEER database. The overall cancer risk was not increased with JAK inhibitors, was not increased with TNF inhibitors, was not increased with other non-TNF biologics. However, JAK inhibitor use was associated with increased risk of lung cancer. Odds, the ones that weren't increased, the odds ratio is 1. The ones that are increased, JAK inhibitors increased with lung cancer, odds ratio 1.40, especially in males, 2.12. And if you were on a JAK for greater than 2 years. Lower rates of breast cancer with JAK inhibitors in women on JAK inhibitors. Wait a second. What did they just say? They just said what you've always heard. The risk of cancer in RA is 1. It's not increased. But actually, that's wrong because certain cancers are increased and others are decreased. The decreased ones are breast. The increased ones are lung and skin and leukemia, right? These are the things, and lymphoma. That's the risk they found associated with JAKs. So is this a JAK issue or is it an RA issue? I believe that's an RA issue. But wait, my next report from the German Biologics Registry, the Rabbit Registry, does great research, really fabulous research. Shows a overall very small increased risk of malignancy with JAK inhibitors versus other biologics. The risk they found was greatest in, and listen to this and tell me what it sounds like, those over 60, those with high disease activity, those who were on 3 or more prior DMARDs. Wait, that sounds like the entry criteria for oral surveillance. A JAK inhibitor study that showed an increased risk. See, I think this data kind of confirms the results of oral surveillance. So this was like 2,200 on JAK inhibitors, 4,200 on biologic DMARDs. The rates, again, 1.4 higher for JAKs. The incidence rates was 11.6 versus 8.9, but the JAK risk only appeared after 16 months of therapy. It was not there in the first year or year and a half. Again, this is kind of confirming data from the oral surveillance study. We're going to end with 2 reports on psoriasis. We've talked about it here. I've had lectures at Room Now Live on this. Does having severe psoriasis increase the risk of psoriatic arthritis? The answer is yes. Does aggressive treatment of severe psoriasis with biologics reduce the risk of psoriatic arthritis? A lot of reports say yes. Some reports say no. People that argue about this talk about all kinds of methodologic issues in the analyses. This is another analysis coming from Dennis McGonigal and another cohort that he was working with. Retrospective analysis of severe psoriasis patients who were either treated with TNF inhibitors or with phototherapy. They were followed an average of 9 years. There was almost 1,000 patients, almost 500 on a TNF, almost 450 on UVB therapy. And compared to phototherapy, the anti-TNF inhibitor-treated patients had half the risk of incident or future PSA. The rate in PSA was 1.18 per 100 patient years. The rate in with UVB therapy was 2.48. So the predictors of developing PSA, if you've got just psoriasis, is having a higher PASI score, greater severity of skin, the presence of arthralgia, nail involvement, and a family history. I think that's a nice report. I like this next report from Philip Meese and colleagues. It was published in Arthritis and Rheumatology. This looks at what happens when the benefits of early intervention of DMARD therapy in patients with psoriatic arthritis. So in this study, 291 patients entering into the Core Evitas, Core Evitas, used to be the Corona database, 291 patients. You're said to get early DMARD therapy if you were initiated on DMARDs within the first year. Late, if it was after the first year, 79% got it in the first year. That's pretty amazing. For those of you who are participating in that, that means you're being very aggressive. Congratulations, wonderful. But 21% were late. if you were an early initiator, you had a twofold higher chance of achieving MDA, minimal disease activity, a superlative outcome in psoriatic arthritis. Likewise, you were going to have a significantly higher chance of significant reductions in your CDAI, the clinical disease activity index of Joseph Smolin. So, both people, whether you got early DMARDs or late DMARDs, everybody got better, but the benefits were greater when given earlier. Again, that kind of supports that whole idea of a therapeutic window of opportunity, right? That's it for this week on the podcast. Hope you enjoyed it. Come back, follow us next week on Room Now. Take care of yourselves.